We're continuing on with Unit 6. This is Part 3. We're going to spend the last part of this lecture discussing ABO discrepancies. And I want to let you know ABO discrepancies are very common. And so you need to be able to, number one, identify, and then number two, resolve the discrepancies. What are some helpful observations that a discrepancy exists? Number one is the strength of reaction. In the forward type, the reaction must be 4+. If it's 3+ or less, it is a discrepancy, and you need to determine the cause. In the reverse type, you're expecting a 2 to 4+ reaction. If you get a 1+ or less, it's a discrepancy, and you need to investigate why. If you get an unexpected negative in the reverse, or an unexpected positive in the forward or reverse. Transfusion must be delayed until the discrepancy is resolved. If this is emergency, give out RBCs, group O, and appropriate D type. ABO discrepancies due to errors are divided into two categories. There are technical errors and there are sample errors. The errors may result in false positives and or false negatives. Sample errors are further divided into red blood cell errors and serum typing errors. You may want to listen to this lecture a couple of times. I want you to know the causes of false positives, false negatives, and the resolution. So the first thing we're going to talk about are the technical false negatives. Failure to add serum or anti-serum to a test is the most common cause of a false negative with students. That's why in the instruction it says add all your anti-serums and patient serums first. Because once you add cells to that tube, you cannot tell whether or not there's serum in there or not. Now with the typing series, okay, I'll give you that one. But I'm here to tell you that as an instructor, this is the most common cause of false negatives. So when I say add all the serums, then visually check to make sure every tube has its drops of whatever. Failure to identify hemolysis is a positive reaction. So you added A cells to the tube and you added patient serum to the tubes and you spun it. And when you looked at it, it was all hemolyzed, but there are no cells. Well, maybe you're inclined to call that negative. Wrong. That is a positive. Hemolysis is always a positive reaction. Not using the appropriate serum or reagent anti-serum to cell ratio. If it says add 3 drops of serum and you add 2, you could potentially have a false negative. Serum has the antibodies, and there is a ratio of antibodies to antigens that give a strong reaction. Too much or too little will cause a false negative. So always follow the manufacturer's instructions. Never guess. Improper centrifugation. If it says spin for 30 seconds at 1500 RPMs, then that's what you do. Let's say that you spun it for 10 seconds. Then you're going to get a false negative because you have not allowed time for those antigens and antibodies to come in close proximity to make those lattices. Incubations of tests at temperatures above 20 to 25 degrees centigrade, which is room temperature, which is in the 70s, 72 to 74, I believe. If your lab, if you didn't record the temperature when you first started in the morning, and it turns out your laboratory is 85 degrees Fahrenheit, you're going to get false negatives. So again, this is a CAP requirement, CLIA requirement. You have to record your temperatures every day. So follow the manufacturer's instructions and make sure the temperature is within the ranges permitted. Use of inactive reagents. Again, never ever take your dropper out of the bottle and lay it on the counter. It can be contaminated with stuff that could then cause your reagents to be inactive. Failure to interpret or record test results correctly. This is crucial. You always, number one, hold the tube in front, have him in your hand, and as you're looking at the tube, you record the results in the proper box. I've had students that they didn't. They relied on their memory and they got it wrong and potentially could have killed somebody. So you hold the tubes after you've gently shaken them off the button, and you hold them in front of your worksheet and look at the reaction and then record your results. I've been in the field over 35 years. I will never, ever put the tubes away, then record my reactions. In fact, if an inspector came and saw you do that, your lab fails their inspection. What are some technical false positives? Over-centrifugation. So if you over-centrifuge, the cells can become so tightly packed at the bottom of the tube that you can get what's called pseudo-agglutination. You're trying to shake it and trying to get it off, and it may chunk off. You said, well, Terry, over-centrifugation, you said, could cause false negatives. Well, true, because you may try to resuspend it too vigorously, and that could cause a false negative. Use of contaminated reagent antibodies or red cells or saline. Use of dirty glassware, which we don't wash our glassware here in the United States, but there's certain areas of the world they do. If there's stuff left behind, that could cause a false positive. Incorrect interpretation or recording of results for the same reason. You look at that tube, you look at the spot where you're going to record it, and as you're looking, you interpret and record that result. Now we're going to talk about problems with red cell antigens, and specifically we're talking about the forward type. If the sample was collected from a recently transfused or bone marrow transplant patient, and for recently transfused, let's say in an emergency, you're going to give group O cells to this person, who then turns out to be a group A. So when you type them, you add that drop of anti-A and you spin it down, you're going to get free cells being released, which are those group O cells, and then a button of A cells that are present. In bone marrow transplants, we can cross ABO types. Let's say we give a group A transplant to a group O person. So, in fact, this is really good news, is when you can start detecting those A cells, that means the graft is successful. So what again will happen is you will get a sea of free cells, which are the patient's group O cells, with a tiny population of group A cells that will be a button. So again, mixed field agglutination will occur. ABO subgroup or weakened antigens due to disease such as leukemia. We talked about this extensively. In ABO subgroups, you have more H and less of the subgroup antigens, either A or B. So we can get maybe a 3+ or a 2+ in our forward reaction. You must have 4+. Or weakened antigens due to disease such as leukemia. Leukemia can actually suppress the expression of ABO antigens on the cells to where you'll get a false negative or a very weak reaction. That's why I say if you get less than 4+, then you need to look at that something's not right. Abnormal proteins or Wharton's jelly. The most issues I've had is with multiple myeloma patients in crisis because they have this incredible amount of protein that can coat the cells, causing them to stick together and be a false positive. Or Wharton's jelly. Wharton's jelly is the gelatinous substance that coats the umbilical cord, and unfortunately some nurses still collect it by, they remove the stopper of a tube and they milk the blood into the tube. This ends up with blood everywhere. It's nasty. It should be forbidden. But unfortunately, this also contaminates the sample with Wharton's jelly that causes false positives. So your baby will forward type as an AB positive, which is the only type we can do on newborns. And then when you test them with the D control, it's positive. And this is one of the many reasons that we use a D control, is to detect a false positive. Cold autoagglutinants. Patient cells may spontaneously agglutinate. And we'll talk about cold agglutinin disease, and these patients make massive quantities, and they have specificity for the I antigen, which is present on all normal adults. So it's an autoantibody that will cause agglutination. Increased A or B blood group substances inhibit reactions. This will result in a false negative, and this is very, very unusual. I've never seen this in my life, but just know that it can happen. You've washed the cells one time, but there still may be enough of these inhibitors present to cause a false negative. Antibodies to dyes in the forward reagents, meaning that you've washed the cells, but there's still enough antibodies present to a dye that it will cause agglutination. I've never seen this happen, but this has gone from the most common to the least common. I failed to mention that the previous slides, whenever we're talking about problems with red cells, we're talking about things that affect the forward type. Whenever we're talking about serum antibodies, we're talking about things that affect the reverse type. So you may get weak or negative reactions due to a patient's condition or IV fluids. For example, as we get older, our antibody levels tend to decrease, and they may decrease to the extent that we'll get very weak or negative reactions in the reverse type, or IV fluids. After looking at hundreds of thousands of red top samples, you know what serum looks like. It is some shade of yellow. If you get something that looks like water, then you have to ask for a recollect. Otherwise, you could be putting the patient's life in danger. Negative or weak reactions in infants less than 6 months old. We've spoken about this. The antibodies come from the mom, they're IgG. You will get negatives. Fibrin clots, if you don't allow a red top tube to clot sufficiently, when you put those drops in the tubes, little fibrin clots will form that when you spin them down looks like agglutination. Now, with my experience, I can tell fibrin versus true agglutination, but at this stage of the game, you don't. But just know that could cause a false positive because it'll be in both tubes. Rouleau, you should have learned in hematology. This is the stack of coins appearance that red cells have in the presence of a protein. And this can cause pseudoagglutination in the back typing. The protein will so heavily coat the reagent cells that they'll stick together. High levels of abnormal proteins in the patient's serum. So again, a disease like multiple myeloma will not only cause problems in the forward type, it'll also cause problems in the reverse type, and it's a nightmare. Transfused with non-ABO identical plasma products. So let's say somebody messed up and, excuse me, they gave a group A person group O plasma, then this could result in the antibodies, anti-A, anti-B being present, and when you recollect that sample or collect another one, we could get false positives. And it's not really false positives, but the antibody discrepancy is due to the transfusion of antibodies against antigens on their own cells. Unexpected antibodies. This used to be a problem years ago, but now they screen all of our reverse cell people for certain antigens. For example, anti-M. Anti-M is an unexpected antibody. An unexpected antibody is an antibody other than anti-A or anti-B. So if your patient had an anti-M, it loves to react at room temperature, and if that reverse cell had the M antigen, you would get a positive, not due to ABO antibodies, but due to this unexpected antibody. Bone marrow transplant with ABO non-identical donor. So again, when this transplant takes place, let's say that you're a group A and you received a bone marrow transplant of group O. Well, eventually those cells will start producing anti-A and anti-B that will react with the A cells. So you could potentially, instead of getting a reverse type as a group A, you'll get a reverse type as a group O, which is good news. It means the transplant is taking. Antibodies to reagent chemicals. This is bizarre. I've never seen it. But when you get chemical antibodies, an antibody to a chemical in the mixture that the reagent cells are suspended in, then those little lattice formations could potentially cause agglutination of the cells by non-discriminately attaching to, and then when you spin it down, causing agglutination of the cells. Let's talk about resolving ABO discrepancies. The first thing you will do every single time is repeat the test. Perhaps you put the wrong reagents in the wrong tubes, or the wrong cells in the wrong tubes, or because we always work with multiple samples, you put the wrong patient's serum into those tubes. You mix the samples up. So repeat. Patient group A with agglutination of A1 cells, test the patient's cells with anti-A1 and the patient's serum or plasma with A2 cells. This is the most commonly encountered ABO discrepancy. We talked about it before. I want to talk about it again. The more times you hear this, I'm hoping it'll click and make sense and stick in your brain. So we have a group A person who is, we have a discrepancy. So the first thing you do is, if they're 4+ with anti-A, then you bring out your anti-A1 lectin and you test the cell. If it's negative, that indicates that the patient's A2. I want to say this one more time. With reagent anti-A, it's 4+. With the lectin anti-A1, it's negative. That indicates this person is an A2. What do they frequently make? They frequently make anti-A1. So that's why you pull out your A1 cell, your A2 cell. Because if this person is truly a group A, they should be negative with the A cells. So you test the patient's serum with the A cells, you get a 1 to 2+ reaction. Anti-A1 is usually pretty weak, but it shouldn't happen with your group A. So how do you confirm the reverse type? Is by testing the patient's serum with A2 cells, and it's negative. So that, in a little nutshell, is how we confirm the presence of a person being an A2 with anti-A1. A decrease in ABO antibodies is the most frequent cause of false negatives in the reverse type. If a false negative is suspected, incubate the reverse tubes at room temperature for about 15 to 30 minutes. What I do is, you rarely ever do an ABO D type by itself. It's always part of a type and screen or a cross match. So what I do is, I've read my tubes. I don't record them yet. I go ahead and continue on with other testing, and then I come back and respin them. And 99 times out of 100, the back type or the reverse type will come down. And again, as long as you can get a 2+ or higher in the reverse type, then that is a valid reaction. If it still doesn't come down after that incubation at room temperature, you can incubate at 4 degrees, which is in the refrigerator, but you must run an autocontrol. An autocontrol is patient serum plus patient cells, and you treat it just like the reverse type. A lot of people have a weak anti-big I, and all adult cells have the I antigen on them. So what we're trying to be careful of is getting positive reactions that are true rather than due to this anti-big I, which is essentially an autoantibody. So as long as the autocontrol is negative, then you can believe the reactions in those tubes. Another trick is wash the patient in reagent red cells to remove interfering substances. Maybe they're inhibitors, or maybe they're just something going on. So more thoroughly washing your patient cells and putting a drop of the reverse cells in a tube and in separate tubes and washing them. Or if problems still continue and you haven't resolved them, obtain a new sample. So let's talk more about anti-big I. Cold agglutinins with a specificity for the I antigen, meaning they're anti-big I, may be strong enough to cause false positives in the reverse type. So in order to prove this is what happened, we will test the sample against group O adult cells, which have the big I antigen, and group O cord cells, which are either I negative or weakly I positive. And when we talk about the I blood group system, we'll learn how that system develops. But initially, when you're first born, you either don't have the I antigen or you may start producing a little of it. And then we run an autocontrol, which is the patient's cells with the patient's serum. Cold agglutinins react most strongly with adult big I cells, and they react weakly or not at all with cord cells, and strongly positive with the autocontrol. Again, the autocontrol is the patient plasma tested against the patient's own cells, which have the big I antigen. So here's what you will see. So you have 3 tubes set up. In the first one, after incubation at 4 degrees, you'll see the adult cells are 4 plus. The cord cells are either negative or weakly reactive, maybe 1 plus, and the autocontrol is 4 plus. This is a way to prove or confirm that the patient has an anti-big I or cold autoagglutinin. Acquired B phenotype is really bizarre. And this is a situation in which, in the forward type, it reacts like a group AB. We have a strong reaction with anti-A and a weak reaction with anti-B. In the reverse, we get the negative reaction with the A1 cells, which is what an A person should do, but there's a 3 to 4 plus reaction with the B cells. So the patient will forward type as an AB, and they will reverse type as a group A. So something's wrong. The acquired B occurs when the red cells from a blood group A patient comes in contact with bacterial enzymes known as deacetylases. These enzymes, commonly carried by bacteria that live in the colon, catalyze the removal of the acetyl group from the residue that gives the A antigen its specificity. This phenomenon is associated with acquired B due to colon or rectal cancer, gram-negative sepsis, or intestinal obstruction. We saw a very increased detection with the advent of monoclonal reagent anti-B that actually drove us crazy. Years and years ago, we made our forward typing reagents from real people. We made anti-A from a group B person, anti-B from a group A person, and so on. Well, with the advent of clones, that you could program these cells to produce an antibody of a single specificity, it turned out that we were seeing a lot of false positives in the forward type. I had never seen an acquired B in my life until we switched to the clones. And we complained, and it's so funny. People, we're having this problem with our anti-B typings there, and they said, well, you're the only one in the whole country who's having that problem. BS. We talked with our colleagues, and everybody was having this problem. So they finally fixed it, and I don't know how they fixed it, but they did, thank goodness, because, again, it caused us a lot of work because there was a discrepancy. So this is a nice little picture. It shows this bacteria, E. coli. It has a deacetylating enzyme that affects the A sugar. So you see it there. It will snip off the galactosamine, and now the galactosamine resembles D-galactose as found in group B people. But it's not exactly the same, which causes a weaker than normal reaction. So I always like to show you examples of the serological reactions because that's what you need to do. You need to problem solve. So in the first example, we have 4 plus with anti-A, negative with anti-B. The forward type is group A. In the reverse type, we have a negative with A1 cells and a positive with the B cells. The reverse type is group A. So they match, so we say ABO group is A. In the next example, we have anti-A 4 plus, anti-B 1 plus. It's AB. You say, well, but the anti-B is only 1 plus. I know that. But what we're looking at is positive with anti-A, positive with anti-B. That is a group AB. Reverse type, negative with A1 cells, positive with B cells. It's group A. That is a discrepancy. Tell me what the patient's true blood type is. You can't. Not until we do additional testing. So these are examples of mixed field agglutination. The picture on the left is microscopic, and with experience, you will be able to recognize that this is mixed field agglutination right off the spot. The agglutinants are very, very tight. They're refractal. They're iridescent. They just look different than agglutination due to an alloantibody. On the right, we have a picture which now I regret putting here because it's hard to see, but there are tight agglutinants and there are free cells. And as you tilt the tube, again, the agglutinants are very tight. In transfusion practice, it's your job to provide serologically compatible blood. This is why it is so important that you know where are the antigens and where are the antibodies and what does that mean. So for a transfusion of whole blood, which with few exceptions is rarely given, it must be ABO identical. So if I'm a group A, I can only get group A whole blood, because if you tried to give me group O whole blood, the cells would be okay, but the antibodies in the plasma are not. So because it has not only red cells, but it also has plasma, it must be identical. For red blood cells, the donors must lack the ABO antigen to which the patient has antibodies. So this is why group O is the universal donor for red cells. And on the flip side, group AB is the universal recipient. And you will start getting angry at TV, because I'll never forget the time I watched a show and this, oh, we have the patient's in trouble. We don't have any AB positive blood. We don't have any AB positive blood. And the doctor got real upset at them. And I'm like, you idiots. This person can get A blood. They can get B blood. They can get O blood. They're the luckiest person in the world. The one who would be out of luck would be a group O if we ran out of group O. So anyway, for red cells, universal donor, group O, universal recipient, AB. Donor products such as FFP and platelet concentrates must lack ABO antibodies to the recipient red cells. AB is the universal donor because group AB people do not have anti-A and they do not have anti-B. Group O is the universal recipient. They can get any type of plasma product because they have anti-A, they have anti-B, and they also have anti-A, B. In the clinical laboratory, a lot of times we work with flowcharts, and blood bank, to me, they were crucial to my understanding. So the following two slides have two flowcharts. I like different things about the different ones, and they both split it into discrepancies caused in the forward type and in the reverse type. So use this as part of your study materials. Flowchart 1, flowchart 2. This is the final part of the presentation for Unit 6, ABO blood groups. The next presentation is all about problem solving through the use of case studies.